Well, hello and welcome to the 27th Degree with Chris and Nancy, being broadcast from the BioSkills of Northeast Studio in Fall River, Mass. Today we'll be discussing Deprescribing with Dr. Donna Bartlett. Before we begin our conversation, I'd like to thank our sponsors, Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Visit Bay Coast Bank or call 508-678-7641 to learn more. And Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. As always, you can support the 27 Degree with Chris and Nancy by subscribing to us on YouTube or your favorite podcast platform, and by following us on Facebook and Instagram. And also, please remember to leave a review, and 5-star reviews are always greatly appreciated. So before we get going, Donna, can you tell us a little bit about yourself? Why don't we start with that?
Sure. So Donna Bartlett, and I am board certified as a geriatric pharmacist. I've been practicing pharmacy for almost 30 years now, which really started off first as a bachelor's degree and eventually evolved into a doctor of pharmacy and then board certification in geriatrics. I started off my career in retail pharmacy, so working at the local chain pharmacy and just spending a lot of time with folks there and working with them. And then later on, I went on to an outreach program. From there, went on and got my PharmD degree. And after that, became faculty. So I work right now as a professor of pharmacy practice at Massachusetts College of Pharmacy and Health Sciences. I am also an author of the book MedStrong and the workbook, MedStrong Workbook.
Great. And I do have the book. It's an excellent book. And if anyone's interested about what we talk about today, which I think is a really fascinating topic, which is also something that I think is really important for your health to know about, the book is available, and we'll talk more about that later on. But deprescribing is one of these things that I would bet that most of our listeners really don't know about. In fact, even a lot of physicians probably don't think about it, although it's something I've been somewhat involved with, obviously not to the level you have been involved with, but for many years in the nursing home setting, because we are always trying to get rid of medications. And there's always this move to add more and more and more meds, and then you just end up with more and more side effects and medication interactions. But tell me a little bit, how did you get into deprescribing? And maybe you can just explain to our audience exactly what deprescribing is.
Sure. So first of all, deprescribing is the reduction or switching of a medication to a safer alternative, or an actual stopping of a medication. So it all depends upon what the patient needs. Sometimes medications are unnecessary and inappropriate, even though they might have been appropriate and necessary at one point.
Sure.
But as we age, our body changes, so that can change too. So sometimes the medications become unnecessary. Their risk outweigh the benefits for the patient. So that might be something that we'd want to stop. Something else might be too high of a dose. As we age, we might not need as much of a medication. So we might need to reduce a dose to reduce the risk of some side effects. And then the third thing is, as we age, some medications aren't safe for us any longer, but we still need treatment. So if we still need treatment, then we want to switch to a safer alternative. So it's still probably a prescription medication. However, it's probably a safer one that's safer for older adults. Okay. So that's kind of how we're looking at deprescribing. How did I get involved with deprescribing? I've spoken to older adults ever since my first day in pharmacy. And what I happened to notice is throughout time is I was seeing a lot of meds that people were taking, and I was being asked a lot of questions about medicines and how long should they be on them for. Eventually, when I continued on to PharmD school, I was seeing a lot of the issues of older adults being at an outreach program, being out in the senior communities, senior centers, speaking with folks, doing brown bags, just medication reviews, just the number of meds people were on, and seeing similar things over and over again and again. I just want to start reducing medicines for folks. And it really got me charged with, I really need to do something more about this.
And I think working with a geriatric population, it even seemed more critical to do that. But this is an important topic for everyone.
Absolutely.
Regardless of age. It's interesting because in medicine, we're always thinking, and we put a lot of energy into what is the right med to put someone on when we're going to prescribe, but we never think of getting rid of meds or changing meds. At least we don't think about it probably as much as we need to. And then patients just really do end up on probably a lot that they don't need. And it's not even that. It's like you mentioned, it's not just a med that's unnecessary. It could be a med that's harmful too. Because of interactions with other meds, changes in our physiology as we age, et cetera.
Yeah. Where do you start? Like if someone's on 10 or 15 meds and you're thinking 6 of these babies could like hit the road.
Yeah.
Like, you don't want to, you don't just do it all at once, do you? Or
Not
you
necessarily. Yeah. So it's a great question because it really is an individualized process that we need to go through with the patients. So typically, what is the biggest problem for the patient? But there might be some resistance too from the patient. So sometimes we're going with the easy things. For example, if someone's on iron, they've been on iron for some time and they probably don't need it anymore, especially if it's been for 6 months or more and they're having issues such as constipation, for example. If we can take that off and now they're relieved of that horrible side effect that they've had, they're like, whoa, this is great. I'm already feeling better. And then they get excited to maybe try to reduce something else too. So sometimes it's the things that you don't necessarily are the most important, but it can help alleviate some of the side effects that someone might be having.
You used a really important phrase there, like feeling better. And I think that's been a trend with a lot of the podcasts we do. Patients don't know how well they can feel. They're so accepting of the status that they're in.
Yeah.
And that
Because
has
it's
to
very insidious when you start to feel poorly for the most, in many instances at least, unless you have an acute illness. If you add a medication and you have a side effect, you've been on the med for 10 years and then for some reason there's another med added and you have some interaction, it can happen slowly. It can happen quickly too, but sometimes you don't realize how poorly you feel from a medication.
Right. And I'm sorry, but I do talk about that too in regards to, I love to give this example of when I was pregnant, I felt horrible. Like you just like nauseous, but you're like, oh, people have it way worse than me. I'm not in the hospital or anything like that.
Right.
But then once that finally alleviates itself and you feel good again, you're like, whoa, I didn't realize how horrible I was feeling.
Yes.
And so we do that. We like, and we let it ride, like you're saying.
Right.
And,
true.
if someone else has it worse than me. And we think about that too. So I can deal with this when people don't have to.
Right. Or they don't want to be like a bother or a nuisance. It's fine. It's fine.
Well, I'll give you a great example. I hear this almost like every other week because I take care of a lot of older patients and a lot of them have cataract surgery. They don't realize how bad their vision is. And then when they have cataract surgery, they're like, oh my God, I can see colors now. Everything is so clear. I didn't realize how poor my vision was because it happened over a period of months to years. And you just don't get a sense. You adapt to it. And then once that problem is fixed, you realize how poorly you really were seeing.
Wow factor.
Yeah.
Can you talk about, as a pharmacist, the relationship that you have with the physicians to start deprescribing?
Yeah, so it can vary depending upon which setting I'm in. So part of what I do as a pharmacist and as a professor, I have a site at a hospital. So I do a lot of internal medicine. I have students that work with me in their advanced pharmacy practice education. And when looking at inpatients, we'll see a lot of issues. And I have the electronic records in front of me and I can see a lot of what's going on. So I can give a lot of examples in actual numbers as to this person has come in with this issue. We're seeing this, this, and this on their labs. We're seeing, discrepancies, and it could be these medicines. So to have that available can be very powerful in saying it could very well be this medicine. The timeline is with it. And some providers are very open to that, immediately want to, make a change or, think about, is that really a cause? Others tend to be not quite certain, not my med, not necessarily the acute issue they're in for. So I want to take care of this. We'll put it in the notes that this might need to be addressed. So it depends upon the med. Depends upon the individual. It depends upon the provider and their comfort. There's unfortunately a lot of barriers for both patients and providers in reducing meds.
But I mean, patients can advocate for themselves too, and I think that's an important point we want to make today.
Absolutely.
Is that physicians, nurse practitioners, physicians assistants, whoever you're following with, sometimes they get overwhelmed or they're busy with everything else going on. They're dealing with an acute medical issue. I don't want to say overwhelmed necessarily, but let's say they're focusing on an acute medical issue. They may not realize the importance of this topic. So patients can advocate for themselves.
Absolutely.
And that's probably a crucial point.
So when
how would they do that?
So when I'm doing med reviews with folks, I review every single med with them. And that's, I think, an important point is some people think that when they go into an office visit, they're checking their medicines. They think that that reconciliation of what are you taking, what do we have on our file is a medication review when it isn't necessarily. A medication review takes time and it's a process within itself. But after doing a medication review, and really it's a good effort of speaking to the patient, trying to get the timeline of various times when they started certain meds. You can kind of see if there's a prescribing cascade that might have happened where one med was started and then eventually another med was added in because of a side effect potentially because of that first medicine. So sometimes those timelines and things like that can be better seen in that conversation. So after reviewing medicines, having a step-by-step, these are different things that you might want to address with your provider and talk about, because you may or may not need this medication. We don't always have access to all of the labs of a patient. So sometimes giving them here's the conversation you need to have.
That's nice.
Here's some questions that you might want to be asking can be very empowering for the patient. And I've heard so many times, I've had such a good conversation with whomever I went to go see because I felt that I went with a purpose and we were able to address that.
Oh, that's great.
So you have this great handout, because I'm like, how would a patient kind of know? But you've kind of done this out pretty nicely.
Yeah.
So maybe you can talk about some of those things as like red flags for a patient.
Yeah. I think a lot of people, and this is part of what I've heard throughout my years of working with older adults, is people love to blame things on age. Oh, I've been so tired. It must be my age, or I'm weak. I can't move as fast, or whatever it might be. They always love to blame their age. And I'm looking at their meds going, it's the medicines, not your age necessarily. So so that is really part of why I marketed it this way in regards to things we love to blame on age could be the medicines that someone is taking. So things like fatigue and weakness and dizziness, unsteadiness, falls. A lot of people don't realize that a medication may contribute. It's not going to be the one factor. Falls are multifactorial, but it could be one of the many things that are contributing to that perfect storm of a fall occurring. So vision changes, like we talked about, you don't realize how bad your vision might be or how dry your eyes might be or that dry mouth that you have. It could be medicines that you're taking. And then if we know that there's some of these side effects, we can then ask about other ones. So if people are having like a lot of dry type side effects, we can start thinking about, well, is their heart rate increased? That's some of the side effects of anticholinergic side effects, for example, that are grouped together. So there's one thing we might be asking some other types of side effects to see if there's a relation that's happening because of a certain medication that somebody's taking.
Is there, to your knowledge, like a gold standard process out there in one of the major health organizations that like this happens? Yeah, because I'm so happy you brought Dr. Bartlett on today as a guest, because I'm like, what's deprescribing? Like, I had no idea
a lot of
this
people
service
don't really
existed.
know what it's about.
So I was like,
Even a lot of providers don't really think about it.
So then I'm just thinking, like I was telling Donna earlier, that I've had my hands on a lot of different types of electronic health records, and you just get those basic flags. It's like, this is a contraindication, or like you don't get
you're
any
wondering if
flags that says,
EMR,
hey,
or maybe with
this patient's
AI
heavily
or-
medicated.
Yeah.
You know?
So there's no gold standard for the deprescribing process. There's a lot of similar ones out there. In much of what is in the literature, the medical literature, is for the healthcare provider to be using. I think it's also important, as we know, to get the conversation going, to get people on the same page, that it's really important that patients and caregivers also know what this process is.
Right.
So that's why MedStrong is part of that, is this 5-step process, is to help patients understand the process so that when they go to a doctor or a prescriber and they say, oh, I don't think this medication is necessary any longer, but the patient has heard you're going to be on this for the rest of your life, that's very different. Right? They're like, you're crazy. I'm not going to go see you anymore. You're telling me I don't need something that I was told I have to have.
Right.
So there's this discrepancy in misinformation, miscommunication, because people are taking it from different sides. What could be happening is the patient themselves have lived a much longer life than what was expected, because that's what's happening. So the medicine that they were taking did help them with that process.
outlived its use.
Now, and now they've outlived it. Hooray! So now instead, let's think about, is this still necessary? Or maybe it isn't. So now, isn't this a great thing? We can maybe reduce that medicine.
Maybe there's something better out on the market.
But you bring up a great point. Like, sometimes patients are really resistant because they were told at one point, you're going to be on this medication for the rest of your life. Let's think about, they're on a statin for cholesterol reduction. Now they're 85 years old.
Yeah.
There's no real evidence that as we age that those meds really do anything, and they probably do cause some harm. You know, there's probably an age where we need to stop some of those meds. You know, what I tell patients in that situation is, you know, the medication has done its work. Its work is over now, and you can get off the med. It's not helping you anymore. And some people accept that and some don't. But it's interesting. There is sometimes resistance from patients, and I think that's why it's useful to educate people about this. But there's resistance on the other side from physicians sometimes.
Yeah.
I think there's superstition. Sometimes we're superstitious. My God, if I stop that baby aspirin, they're going to have a stroke next week, and I'm going to be to blame. Or if I stop that statin, they're going to have a heart attack or a stroke, and I'm going to be at fault. So there's a lot of that goes on, a lot of worry.
But rightfully so. In the reason why I say that is, we are an evidence-based medicine type of healthcare system, and what evidence is out there to deprescribe, it's not as robust. We know how to start a medication, how to increase it, how to keep it going, and not necessarily is there any information on how to stop or deprescribe. There's some pockets of it. There's some great programs out there. Deprescribing.org is an excellent one that has some algorithms on reducing some medications, but it's not every medication. So who's responsible for this? Are manufacturers going out and saying, okay, when are we going to stop this med?
Unlikely.
I don't think so. So there's that apprehension that there isn't that evidence base. So this is when we really have to start, looking at what's going on and doing that real individualized approach to somebody's health and how they're feeling. Another thing that you brought up is statins. And over time, we talk about, if you're feeling weaker. Well, statins are known to reduce muscle mass for folks and weaken their muscles over time. So if somebody they've been maybe a little bit achy over the years, they don't say like, oh, it's the statin. But once they stop the statin or reduce the statin, they're like they're not as achy and they're moving a little bit better. So sometimes it's those things too
and it can be a little bit from one med and another combined can cause a really big problem. It may not be just one medication. But
those additive effects for sure. And there's so many important factors with that we need to look at. Thinking about things for sedation or muscle pain. Also, medicines that might increase the risk of bleed is also an issue. So there's a lot of those additive effects out there that we have to be careful of.
So we started to talk about this, and I think we went in a different direction. But make believe, for example, let's say Nancy is a patient, and you're approaching her and doing a review of her meds and considering potentially some interactions where deprescribing may be appropriate? How would you approach her as a patient? What do you do exactly as a pharmacist? Because I mean, physicians should do the same, really, type of thing. And so,
Sure.
tell us a little bit about how this looks.
Yeah. So what I first do is just start to have a conversation with you about all of your medicines and a little bit about your history. So I ask you about, the standard health conditions, and we start having a conversation about things.
Right.
And then I start asking about your medicines and how long you've been on them for. Because that is another key factor is how long, when I hear 10, 20 years, or I can't even remember, I start going, okay, and start looking that through.
Right.
I like to do that timeline too. So there is some key things that I like to think about too is the why. Why are you taking this? So if you're taking something, do you know why you're taking it? Do you think it's still helping you? Do you think the problem still exists? So if someone says that they've been on omeprazole and it's been a couple years, when was your last acid reflux issue that you had? If it really hasn't been, I know you've been on it for too long at that point, but typically, that's one medicine that we only want to see people on for a few months at most, not a few years. So once I start seeing some different things, I'll start asking about side effects, or I'll say, for example, if you're using something for sleep, do you take it every night for sleep, or is it only as needed for sleep?
Right.
So I'm really getting into the why. If you're taking over the counters, I'm asking, why are you taking that? What prompted you? What's value does that have for you that, you think you need that fish oil, that you think you need that aspirin a day when it might not be appropriate for you? Who told you, for that guidance? So when I'm looking at that, then I'm, kind of getting that scenario under my belt. Prior to even seeing you, I'm asking you for your list a day before so I can run everything through interaction checkers and kind of see what's going on. So I'm checking on that. And then I might start talking to you about if you have some labs available, so what is your typical blood pressure? What is your typical heart rate?
Right.
Do you have a cholesterol level with you, or whatever I might need to see? Sodium levels sometimes are important, or electrolytes, for example. What's your magnesium? So those are some things that I try to target if it's appropriate. And then we start having the conversation about, this could be happening. You're taking this and now you're taking this. It could be a side effect. We could maybe switch this med if you still need treatment, and then we can eliminate some other meds for you. So if I can just share one great example with you.
Please do.
So there was a gentleman, this was years ago, he had called the outreach program when I was there, just had told me that some of his medications were a little bit expensive for him. He's on 6 meds, so not astronomical, but 5 or more is considered polypharmacy.
Yeah.
So he is taking some meds, and he tells me that he was taking a torvastatin, a statin for his cholesterol, and then he was also taking ezetimibe so that he could lower his LDL. Well, eventually he wasn't really getting his numbers down, so they switched the atorvastatin to rosuvastatin once it became generic for him. Then his numbers started looking great, and I was like, "But you're still on the ezetimibe?" And he's like, "Yeah." I go, "Well, it might not be appropriate. That rosuvastatin was probably your workhorse for you." I said, "You can probably go off of that." He was also on niacin to up his HDL. Get off of that. He was also taking an omeprazole that he had in the hospital after he had a cardiovascular event. He didn't need it anymore. So he went down to only 3 meds out of the 6 meds he was on because he didn't need all these other things.
Right.
And he worked with his doctor step by step, reducing those cholesterol meds that were no longer necessary.
Right.
So making those changes, we forget to think about what are all these other things we've added on.
Putting it all
And he
together.
was so excited when I followed up with him. He's like, "This is incredible." And he was just so happy
And
about
his
it.
cholesterol was just the same.
Yeah, I mean, yeah. But it was perfect, like with the
That's interesting.
rosuvastatin. Yeah.
Yeah.
So this is a question for both of you.
Mm-hmm.
Just when you're dealing with a patient, and there are many who have a number of specialists, like they might see a cardiac guy, a neuro guy, a pulmonary guy. How do you collaborate and pull that all together? Because I'm going to make an assumption that you might be hesitant to pull away a medication from a specialist that a specialist prescribed.
Well, I think as an internist, in a primary care doctor, a lot of it comes down to communication with the specialist. I certainly wouldn't stop a medication that a cardiologist had started without a discussion, but and it takes time. This is the unfortunate part to this. We're all busier and busier all the time, and this does take some effort. Right. It's much easier to prescribe a med or just leave things the way they are than it is to get rid of a medication at times, unless you own that medication. If you're the one who prescribed it, it's easy. But, if it's something that someone else prescribed, it does require a discussion. Now, there are certain things that specialists may prescribe that are non-critical meds that I don't think are going to, if I stop them, it's not going to be a huge issue. But
Right.
certainly cardiac meds and some of the pulmonary meds, it would require a discussion.
Okay.
If they're on, let's say a medication for overactive bladder and, they're still having issues with overactive bladder and incontinence, but they're having now other side effects. I would just stop that. I feel very comfortable doing that. I do that all the time. And then, they can go back to the urologist and I'll send them a letter and they can talk about it. But it just depends on, I guess, what the medication was initially prescribed for. I would feel comfortable stopping some. Some would require a conversation.
And
A long about answer, sorry.
no, but that was very good. And what's your perspective on dealing with the whole health team?
Yeah, difficult. I definitely see, like you're saying, that hesitancy of reducing a medicine, deprescribing a medicine that somebody else has actually previously prescribed. I will give you just a quick scenario, though, of a very close story to me. And so knowing someone that I care for who was on a medication for 30 plus years cardiovascularly, and I'm just, they don't need this anymore. They really don't need it anymore. And the cardiologist that we were seeing no longer, she was hesitant about it. And she says, I didn't prescribe it. I'm like, you're the cardiologist now. Like, let's do this, And so it took some coaxing and some work together. And I'm like, I will pay attention, let's do this together. And so finally we're able to reduce that medicine and stop it. And the person is perfectly fine off of the medicine. So it was necessary, right, many years ago, and it just wasn't necessary any longer. And it took some time to, it's a constant conversation. It really is like every time that you see a patient or every time that a patient sees a specialist or their primary care, this conversation should be happening. Mm-hmm. It's not just up to one person. It's up to the patient too and the caregivers too, and to embrace that whole team and talk about all the meds together.
Primacare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. Primacare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. Primacare is large enough to take care of all your medical needs, but small enough to care for you personally. Primacare is by your side.
Yeah, it's really a team effort, and it does take a lot of coordination and time and effort. Mm-hmm. So, one thing that you mentioned I think is critically important for patients to know is that when the medical assistant comes in the room and they look at the meds and they reconcile the meds, that's what they're really doing. They're just saying, okay, you were on this med at this point, you're still on it, you're not on it, or whatever. That's not the same as what we're talking about here, which really requires a lot of effort. You have to look at each med, like you mentioned. Mm-hmm. What's the history of that med? How long have they been on it? Why are they on it? Do they still need it? Yeah. Were they put on it as a side effect to another medication, which is always that happens not infrequently. It takes a lot of effort. It's not as quick as what the medical assistant does in the room.
Absolutely.
Does it ever get tricky, like with the certain algorithms that you have to follow? It's like the person has this disease, the labs are this, recommendation is you put them on this, but you're like, does that ever get tricky where you're like,
I don't get a lot of those algorithms from my particular EMR. I know other EMRs do that where you have a diagnosis and they give you recommendations of what to do. So I'm not really getting a lot of that. So for me, no, it's not tricky at all. I just use my brain and order what I need to order. But I know there are EMRs that do that, and that has its pros and cons.
Yeah. I think what happens and what we'll hear is that insurance companies will look at certain
Well, that's where I get a lot of it.
Too.
Yes.
And so because of that, it's kind of a catch-22 in that, you have to prescribe something, but it might not be safe. So for example, someone's blood pressure might be high, especially in older adults. But what is appropriate for that patient? If you add on more med, they might get dizzy, lightheaded, and fall. So they might get their blood pressure down, but to what extent?
right.
And so that becomes problematic when they were actually fine a little bit higher, but they didn't meet the exact criteria.
Right.
So you're being
I get that all
careful,
the time.
but you're not, they're out of the target range.
So I get that all the time. In our EMR, if someone is over 140 overnight, the blood pressure is flagged. It's red. So that's great if someone is younger. But if I'm working in a nursing home and I use the same EMR and they're 95 years old or 90 or even 85, and that's their blood pressure and they have a history of falls, I'm fine with that.
Yeah.
That's okay. Or hemoglobin A1Cs get flagged if they're over 7. Well, if they're in a long-term care facility, they're fine if they're 8.
Yeah.
But these are things that the computers are very rigid, unfortunately. Maybe with as things progress and we have true AI, it will be better. But right now it's kind of black and white. So a lot of this stuff probably does push some providers to order things that they don't need to. Hopefully, most of us use our brains and just go by that. But it is interesting. So yeah, we do get a lot of that. And then I think the difficult thing for us is the huge amount of information and paperwork and recommendations we get from the insurance companies because they don't really know the history. They're not taking a history on the patient. All they have is diagnosis codes and meds. They don't know anything else really about the patient or their history. So, someone can be 95 on hospice and they're recommending a statin or, it's kind of crazy stuff that comes up.
Yeah.
So they have heart disease, so automatically they should be on a statin and aspirin and this and that.
Right.
But realistically, we know, the patient is really advanced in their condition. They're more end of life.
Right.
That's not appropriate. But the insurance company doesn't know that.
Yeah.
So we get inundated with that stuff. And it requires a lot of work.
Waste. Yeah.
It really is a waste, actually. I think a minority of that stuff is probably useful.
Right.
But
right.
what's more useful is a human being like yourself going through a record, spending some time knowing the patient, and then making a legitimate recommendation. But when it's all from basically, you hit this target and a computer says, okay, you should be on this, and they spit out a form letter, that's probably not as useful. And we get a lot of that.
Yeah.
Are there some things that you consistently run across that is just like a broad stroke where, okay, if you're on this, you don't have to do this. Do you see those things coming up like again and again?
Yeah. So it's interesting in some of the things that I've seen throughout the years, especially at the hospital site where I'm at, and what I've seen shift, which is really pleasing. So for example, when I first started, gabapentin through the roof on everybody. It was just everybody was on such high doses and inappropriately so, especially for their kidney function. So they were just way too high. And so getting that back, and now people come in on these high doses and it's automatically just reduced, which I absolutely love to see that. I rarely have to make that comment any longer. I think the one that does slip through is really advanced kidney issues that a really like reduced dose if a patient does still need gabapentin. So that's one thing. The other thing that I've seen over time, still see it, but I'm seeing less of it, is citalopram and escitalopram especially. Those are two products that we have to be really careful in older adults as to the maximum dosing because of this QTC prolongation is what they call it. It's the what happens timing of their EKG, and we've seen that being reduced too. So people coming in on high doses, we're seeing that automatically reduce. So those are some big things. I think the hard thing that I see is the polypharmacy. You'll see it noted, polypharmacy, but no one knows what to do with it. And especially with sleep products, with mental health products, and those are some real big areas. And no one really wants to touch them, but it's so necessary to do so.
Yeah.
Is it hard? I'm just thinking of all the sleep products out there, and then you look at the dispensaries and everything. How do you know what exactly is the content nowadays on the over-the-counter meds?
Stuff, yeah.
Like that has to be hard to figure in when you're looking at something because there's no standards.
Well, I mean, the over-the-counter stuff you buy from CVS in your pharmacy, you know the milligram strength, but I don't know. I mean, if you're going to a dispensary, although they do tell you the milligrams of THC and whatnot, I'm not sure. I wonder about the accuracy of that. I don't know.
Yeah. I'm not 100% on that. It's not an area of expertise of mine, but they do have certain standards, I guess, but it also depends upon who you're going to, like in their level.
I would bet there's some variability.
I bet there is too.
I would think there probably is, but a lot of the over-the-counter meds, and this is an important thing for the audience to hear, they're not really safe. There's a lot of really dangerous drugs out there that people take and they don't think about. I get this all the time. I can't sleep, so I'm taking Tylenol PM. Okay, so you have two drugs in there that probably you shouldn't take. So first of all, why are you taking acetaminophen? Do you have pain? No, I don't have any pain issues. I'm taking it for sleep. Okay. And the other drug is diphenhydramine, Benadryl, which causes a lot of falls and issues with the elderly. And it can cause a lot of issues during the day that patients aren't even aware of. They think they're fine and they're alert, but then they get into a motor vehicle accident. So, really bad, really a drug you should take with a lot of caution, I think, is diphenhydramine or Benadryl.
Absolutely.
And, you're probably not going to overdo it with one dose of Tylenol in the evening, but why take it if you don't need it?
Exactly. There's also that confusion too. There are cases out there that people think that they're taking Tylenol, but they have the Tylenol PM. They're taking it throughout the day even, not realizing. There's a lot of issues with, they call it brand extensions. So in pharmacy school, there was always the brand generic, right? And I'm sure that it was the same for medical school. You have, you have brand generic names, and that was what went together. But now brand names vary, especially over the counter. So Claritin that's used for orally is different than Claritin eye drops, and they're different. So if someone says I use Claritin every day, then what are you doing? You're putting down loratadine, or you're putting down the ketotype for the eye drops.
But it's very dangerous, and the pharmaceutical industry seems to be embracing that.
Yes.
They're using the name, but it's a completely different chemical.
Exactly.
Actually taking, which is interesting.
So that can be very confusing. And so part of what I try to educate people on is make certain you give the entire product, that you're saying what it is that you're taking. We've had patients into like with Excedrin. Well, which one are you using? And then we find out that it's the Excedrin migraine, but it also has NSAIDs in it. And so that's why your kidneys aren't doing so well right now. So these are things that we really need the full name that people don't necessarily think.
There are a lot of over-the-counter drugs that are dangerous in their own right, but then many of them interact with other prescription drugs that patients maybe are like, patients don't think much about taking, for example, St. John's wort. That has a lot of medication interaction. Non-steroidals. Everyone thinks it's so safe to take a little ibuprofen, a little Aleve, or Motrin. It's really not. You see tons of GI bleeds, kidney insufficiency, hypertension, which can lead to stroke, all from these over-the-counter meds.
A lot of folks will say to me, oh, that's only for older people, right? I'm like, no, perfectly healthy people end up in the hospital because of NSAIDs, because of the ibuprofens and naproxens out there, for all the reasons you just stated. So, so yeah, it doesn't matter the age on these. Healthy people with healthy kidneys and et cetera can still have issues.
So I would recommend to all the patients out there who are listening to this, if you're taking over-the-counter medications, first of all, talk to your physician about that. Let them know what you're on, because if you don't tell them, they don't know. But really be cautious about what you're taking. There are a lot of over-the-counter medications that we think are so safe, but really are not.
Right.
Here's another thing. If for some reason, and this was very common practice years ago, and I still see it, if you are on a medication such as Seroquel, which is an antipsychotic for sleep, you should get off that medication, absolutely. Unless you're on it for a psychiatric issue, you have a high risk of developing a permanent movement disorder called tardive dyskinesia. And you don't want to develop that, because it's not something that is going to go away. A lot of patients on those meds for sleep.
That I just don't understand, and how that has really taken off as being prescribed for sleep. Of course, it's a side effect. It's like the diphenhydramine being used for sleep over the counter,
It's
but
a side
it's a
effect of a
prescription. It's a
medication.
side effect to produce that sleep. And you're absolutely right. I see it and I go, why? Is this person even on this?
I think a lot of it started in the hospitals. What I saw was, some of it in the outpatient world too, but I used to see a lot of patients come out of the hospital on Seroquel for sleep, and then it worked. So they were really hesitant to get off it. And then down the road, you end up with a really serious problem, unfortunately. So I don't think we should be using meds for their side effects.
No, I agree too.
But there's a lot that are out there that are used in that manner.
Absolutely. Well, and like we talk about it too, there's a couple of meds that are overused and really overprescribed, and it's all for unlabeled use.
Right.
And we already talked about it's gabapentin, but the other is trazodone, and they're used for so many reasons that they weren't intended for, which might be appropriate for some, but it's not necessarily for the millions that are taking these. So things to really be talking about and having conversations.
Sleep is a really tough thing, because patients do suffer a lot with insomnia, and they're really hesitant to get off these meds. But really the appropriate thing to do is, it's really cognitive behavioral therapy for most patients, which is hard for two reasons. One, it's hard to find someone who can do the therapy. But secondly, it takes time and effort.
Yeah.
And we all, as a society, want that easy fix. And sometimes easy fix is really harmful in the long run.
Yeah, for sure.
Can I ask you a question, both of you, about the sleeping medications? I've always heard that, the sleep medication will work for a little while, but then it doesn't work. Why is that? Like, what happens to make your body get used to something, if everything I'm saying is even true?
No, for many meds, it depends on the med, but you can certainly take this one.
Yeah.
if you like.
So, well, it depends. There's this thing called tolerance, and your body builds up a tolerance, so it gets used to it. And then it doesn't seem like it's working as well. So then, therefore, you increase the dose, or you take a little bit more so that you have that effect. So that's a tolerance that occurs. There's also this thing called addiction, but that is something else. But tolerance does happen in the system, where we just get used to it, and it's not as effective. But with that, is it every single night that someone has trouble sleeping? It might be, but you don't want to just start taking something every single night either. You want to really use it as needed. That's the intent of a lot of these sleep aids, and yet it's put on as take it nightly, and people get used to it and taking it nightly, and then they think they need it. So we'll find that it's funny that you're talking about sleep, and then I also talked about like that stomach acid too, where people stay on these meds inappropriately for a very long period of time. And it's because they feel these things, right? They don't want to feel insomnia. They don't want to feel stomach acid. It's horrible, right? And so those are the things that are hard to come off of, and they take time, and it's a slow, gradual taper that needs to occur. A lot of meds need a slow taper in order to reduce, and it's difficult, and people don't necessarily they might think like, oh, I just need to stop it. And then they stop and they have a horrible rebound of something.
Right.
And then they're like, oh, I need this. So it's hard when they feel that, when they feel anxiety, when they feel insomnia, when they feel stomach acid. Those are the meds that are really hard to come off of.
Yeah, I think people forget that about the meds like omeprazole, the proton pump inhibitors. They stop it. They have recurrence of their symptoms, but you have to stop. If you've been on it for years, you have to go very slowly to come off those meds, just as you would with an opioid or a benzodiazepine like, lorazepam or diazepam.
Yeah.
You can't stop those very quickly. The taper can be over months.
Absolutely.
Okay.
You made mention earlier with your example of that gentleman who was on 6 medications and then he was on 3. And we talked about the outcome being that he was very happy and felt good. But there's also that significant cost, that's associated with this that, is not to be ignored.
If you look at what Americans spend on pharmaceuticals compared to other countries, it's actually very striking. We spend way more than probably necessary. And not just prescription drugs, over-the-counter drugs, supplements, another huge. And I do like certain supplements myself, but we spend a lot of money on all this stuff.
Well, yeah, and I'm just thinking of like the people that are turning 65 and they're going to their shine counselors from the Council of Aging, and they're like picking their plans based a lot of time on what kind of medications they're at. So they're not spending so much out of pocket. So
that is a great time to be thinking about having a med review because you have all your meds there.
Right.
You have the list. So when people are thinking about, hey, I have to pick a plan, you got your list. It's a great time to do a med review too.
absolutely.
I know that the podcast is not necessarily about this one topic, but maybe we can just spend 30 seconds talking about anticholinergics in the elderly because I think it's just such a crucial topic and such a point of problem with patients.
Yeah.
And I'm sure that when you're prescribing, you're looking at a lot of anticholinergic effects.
Absolutely.
And patients don't really understand what that is.
Yeah.
Maybe we can talk about that a bit.
Yeah. So anticholinergics are things like diphenhydramine, that PM sleep aid. Also things that are used for urinary incontinence too, such as oxybutynin. But things that cause dryness, if you think about it, dry eyes, dry mouth, urinary retention. These are things that also then can increase the heart rate for somebody too. It can cause you to feel confused, and it can also increase the risk of falls. So there's a lot of things going on with these particular types of medicines. We talked about that additive type of side effect. And so I talked about some main ones that are, like we talked about the urinary incontinence and antihistamines, but also some antidepressants have that type of side effect incorporated in their chemical structure that will have the effects for individuals. Muscle relaxants have that. So there's a host of many different medicines that have this, and there's different levels to them. So we can actually check on your anticholinergic burden to see where you're at. And if you're at 3 or more, then we need to be careful. We have to start taking action because that means you're more likely to have a fall, a hospitalization, or, unfortunately, if you fall and have a traumatic brain injury, death could occur too. So it's really important that we talk about anticholinergic burden and reducing this. Again, it's something that we can do slowly and try to take away meds so that we get you down to that lower number. So when I'm doing med reviews, I'll actually do an anticholinergic burden number. And then as we reduce medicines, we can see how that number is dropping. If we can reduce that number, then the patient's going to feel better.
Right.
Perfect.
I mean, some of these anticholinergic effects can be the difference between someone living independently or not, or a fall that produces, like you mentioned, a life-ending head injury or a hip fracture, which can also be, if not life-ending, certainly independence-ending.
Yep.
So they're really, it's really crucial. It's a crucial topic.
It is.
And there are just a ton of anticholinergic meds out
Can you give
there.
an example of a few for the audience?
Of
The common.
Yeah, it's, diphenhydramine, which is Benadryl. Some of the bladder meds, antispasmodic meds like oxybutynin, that's another one. Let's see, what else did we mention here?
So dicyclamine, which is
Yeah,
used for stomach.
Muscle relaxants.
Yes, muscle relaxant, cyclobenzaprine, for example. But then we also have antidepressants. So paroxetine is one that is a much higher anticholinergic burden than, say, sertraline. So they all kind of have it, but there's different levels to it too. The older tricyclic antidepressants like amitriptyline, that is something we should not be seeing patients on.
I just never used that anymore. It was very popular years ago.
So those are some of the things. And then, believe it or not, there's also some very common meds that might have a low score. So say, for example, furosemide, which is a diuretic, metoprolol, which is a beta blocker. Those also have a little bit of an anticholinergic burden. So they add on and they can really start increasing those numbers.
You never really think of it with those meds.
Yeah,
You're right.
exactly.
If you add it to a few others, it
can get those numbers up.
burden.
But those aren't the ones that you'd necessarily target first to remove. But like I said, they can get you that 3 and above.
There's a lot of low-hanging fruit.
Yes, absolutely.
Yeah, definitely.
Can I ask you just one question that I'm kind of interested in? Being a professor, have you seen certain trends like coming out now that you're happy about, or trends that maybe you're concerned about with like the younger crew?
So for the students themselves and what they're coming through as, wow, this is quite a question. And
just like just within your field too, like what's
absolutely
which way is like the pendulum swinging kind of.
So part of what is always surprising with the students when they have me on rotation is I say to them, okay, you need to find a patient and make a recommendation. Okay. And they're looking at me going, well, which patient? And I'm like, pick a patient. Because it's that much that that we're overprescribed and over-medicated. And they're always shocked to think that. So sometimes their response is, like, what are you talking about? And very questioning. And
I think it's a rare event.
Yes, exactly. And then they're like, wow, I'm thinking completely differently by the time the whole rotation ends. Wow. But part of it is what they're able to research and get quickly. Like, that's pretty cool. I'm thinking about when I went to school and the drug facts and comparisons that we had to, switch the pages for. Everything is readily available, and I'm always saying, look it up. Yeah. Don't look at me for the answer. You have to be able to look it up and make sense of it. Right. So sometimes they're surprised with that, thinking like that I'm supposed to be telling them everything and teaching them everything. I'm like, this is how you're going to learn, and then we're going to discuss it. So some of that has been, I think students don't quite know how to approach that at times. Yeah. And then they're surprised at the end. I don't know if that really answers your question.
No, it's a great answer.
But I just think that them being able to say, let me look that up, I think is okay. There's so many drugs out there. There's no way. I'm like, I'd rather have you tell me something correct if it takes an extra minute versus something incorrect, because we have to be correct with the information we're providing.
Nice.
I think from my perspective, what I see that's maybe positive is that I see when patients come out of the hospital, they're much less likely to be on antipsychotics for sleep. They still are coming out on proton pump inhibitors like omeprazole for sometimes unclear reasons. But there's more. I think there's more knowledge about this, and I think as providers, what we should be doing is thinking every time we start a medication, we have to consider that they may be on that medication for the rest of their life unless we intervene or someone intervenes. So you really have to think about whether or not, one, there's a good reason, and two, whether or not there's an interaction or an issue with any of the other meds they're on, and why are you really doing it? I mean, are you treating a side effect of another med?
Yeah, for sure.
Because we see that all the time.
We do.
Someone's on iron, then they get put on a stool softener or a laxative or whatever it may be, and oh, now they have diarrhea, so they keep the laxative, but now they're also on the modal, or it happens all the time. So because there's these lists get long, and I think providers sometimes don't think about.
Yeah,
it takes a lot of time, but it's so important for the outcome of our patients.
absolutely. I'm always amazed by the lists of meds that I do see.
Yeah.
And I just go, why? Why is that?
No.
So we do have to
We have to rein it in a little bit.
in,
Yeah, as best we
for
can.
sure. Yeah.
As a visiting nurse, we have our binders with our med list in them, or we're scrolling down on the computer screen. It's just like, turn the page, scroll down. It's just like
Yeah, and a lot of them are
so long. And I was saying,
so
like,
unnecessary.
we're all on these electronic health records, and yet the flags we get are so basic. Like, this is a contraindication. It's never, wow. It's on a lot of meds.
Yeah. Fortunately, a lot of this still requires providers to use their brains. And I hope computers don't just take over this whole field.
No, not to
But,
take over, but let's use them to their advantage.
I don't think
too.
it's there yet. I mean, a lot of the stuff we get now is just garbage. I don't know.
Yeah.
I'd rather have someone like yourself look over this, and it's so complex. I just don't know how it can be done any other way.
Yeah.
Computer's
No, I
not taking
agree.
a history,
I agree.
there's so much to this.
Yeah. We need pharmacists in practice
Right.
too.
Right.
That's what I'm hoping for someday, is that we're recognized to be in a practice, that visiting nurses, pharmacists are not part of that entity. They should be. There should be pharmacists that are part of that.
I mean, we're really fortunate in long-term care, that we do have pharmacists that interact with us, because it's not really like that. Certainly not in the outpatient world. And I really feel bad for the pharmacists in retail pharmacy, because I don't know how much they're able to do as far as what they were trained as pharmacists to do.
Yeah.
It's hard.
It is
It's
hard.
a really hard field.
It's a really hard field, and they're hammered with numbers.
Numbers.
And if you think about it, like, I have the luxury of reviewing somebody's meds and then having a nice conversation with them, because I'm removed from the retail world.
Right.
The unfortunate part is I can't bill for that. If I was in retail, then I could bill for it.
Right.
So it's it's a catch-22, but they don't have this kind of time. You'd have to, have a designated pharmacist in order to be able to do that. And not only are they looking at and taking care of all the meds, but also vaccinations too. And
It's so complicated. It's such a hard job
going
now.
on. It absolutely is.
Yeah, I just, I have a lot of pharmacists who are patients of mine, colleagues, and,
Yeah.
the ones in retail, I just really, truly do. My heart goes out to them. But the ones that are in, I think, long-term care seem to really enjoy what they do, because they're really doing, what they trained to do in many instances, which is nice.
Absolutely. Yeah.
So I can't believe an hour's gone by already.
I know.
But it has.
I know.
And unfortunately, we could talk for hours on this.
We could.
And maybe we'll have you back at some point, because I do think we went over so many important topics, but we really just scratched the surface. Is there anything you want to leave our audience with? Maybe, a couple words of advice, a story that is compelling, whatever you feel would be useful.
Sure. What I think is really important is that every encounter is an opportunity to try to reduce meds, no matter where somebody is, whether they're at the pharmacy. If you're at the dentist and you have dry mouth, that might be a good conversation to start talking. So I really think any encounter with any healthcare provider is an important one to just even start the conversation. What I would love to see on the other side is for providers is at physicals to have a column continue or deprescribe and really start thinking about that conversation at least once a year to have that check-in. So I think that the patient education, caregiver education, and providers, think we're coming together, and I'm hopeful.
Yeah, no, I am too. I think as more of this gets out there, hopefully we'll end up in a better place than we are now.
Yeah.
And it's really, I agree, patients need to be a little empowered too, and they can bring this up to their providers, and it would be helpful to do so.
Now, you also have a podcast that you do. Maybe you should tell our listeners what that's all about.
So the podcast is called The Med List, and Kevin Walker, a pharmacist out in Washington State, and we actually do a podcast once a week on Mondays. We just happen to be taking this month off in between the holidays to ramp up for our third season. But anyways, we do talk with a lot of different providers, but also a lot of people in the field that might be encouraging exercise or like Parkinson's specialty or various disease states that people might want to think about their health a little differently and how the medications might play a part and how other factors might be able to play a part in the health of the patient.
How often do you do the podcast?
It's a weekly podcast.
It's weekly. So, and you may have mentioned this, but if someone wants to find your podcast once again, how do they do that?
Yeah. So we're on YouTube and Spotify and Apple and a lot of those different ones, and you would just put in The Med List.
The Med List.
3 separate words, and you should be able to find us.
And then we've got the books here too. We should probably show our audience. Do you think this is more appropriate for patients or providers? I have this book here. It seemed like would it be useful to patients?
Yeah.
I think it's a little bit of both, maybe.
Yeah, it is. My first thought is for patients and caregivers, but what I've found is that a lot of providers are really embracing it too, and found it useful. So it's really just to get that conversation going. And I do say in part of it at the beginning that some of the later chapters are maybe more for providers, and some of the earlier chapters in explaining polypharmacy, deprescribing, and the 5-step process is part of that for the patients and caregivers. And then the workbook came out as a blow up, if you will, of the 5-step process, and it just really takes people through the 5 steps. There's a lot of forms in there and a lot of questions to be thinking about. What are you reluctant about? How long have you been on a medicine for? What is keeping you from having a discussion about reducing meds, or what's important to you type of questions. So a lot of that is taking people through the workbook so they can have better conversations.
Well, thank you so much.
Thank you.
Really appreciate you being on the show. It's such an important topic. You have a passion for it, and there's a clear need for a greater understanding of the importance of this topic. So I want to thank Dr. Donna Bartlett for coming on the show. We really appreciate it. We'll have you back at some point, I hope. And I want to thank all of our listeners for listening to our show. And if you'd like to become a sponsor, please contact us at 774-319-4230. Special thanks to my good friend Ron Gamache for our intro music, Primacare, your trusted medical providers in southeastern New England, and the BioSkills of Northeast for producing our show, and available to produce your show, and they do a great job. And if you're interested in that, please call 774-301-8811. Bay Coast Bank, just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. And Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. Thanks again, everyone, and we'll see you down the road at our next podcast.
Thank you.
Thank you, Donna.